Good evening, friends. This 150-second webinar. With this webinar and previous few webinars, we are going a little deeper into understanding patients' needs and our goals of treatment. We started with more of clinical, but now when we have to take a decision on how to treat and what should be the goal of a patient, we have to be little more insightful. So during my research on the internet, I found this study. Now, when we treat diabetes, we are knowing that the target for every patient is same, fasting around 90 to 100, PP around 140 to 150, HbA1c below 7. And based on the patient's baseline reading, we start a treatment and we achieve that result. Similar in hypertension, there are guidelines which tell us to start monotherapy, dual therapy, triple therapy, or insulin. Or in hypertension, single therapy, double therapy, triple therapy. But in LDL cholesterol, which is the single most risk factor for atherosclerotic coronary disease, we have to be more careful because goal for each patient differs. That is why this webinar. Let's begin the journey. Atherosclerotic cardiovascular disease. LDL concentration, as we all know, among all 5 parameters of lipid profile is central to the pathophysiology of atherosclerotic cardiovascular disease. When I say cardiovascular, it means heart as well as the brain. Lowering LDL cholesterol to appropriate guideline-directed goal. Now, what is the guideline? The pathology reports give 5 parameters. Below 100 is optimal. But now we all know the targets have reduced to 70 and maybe 55 in some cases. So appropriate guideline-directed goal is to reduce the atherosclerotic risk. So we'll see in today's talk how to calculate the risk and then how to target it to bring it down. Research happening across the globe has taught how much LDL lowering to expect for any LDL cholesterol lowering drug. You cannot expect beyond a certain level of lowering from any drug. Prescribing the correct combination of lipid lowering treatment to reach patient's goal should be easy once you understand what is that patient's risk, what is that patient's goal, and how much you have to bring it down. So when deciding the risk profile or the risk quotient of a patient, you have the patient's clinical profile, patient's weight, BMI, history of hypertension, history of diabetes, smoking history, and then you have LDL cholesterol level done of that patient. This together gives you the risk of atherosclerotic cardiovascular disease. What are the indicators of atherosclerotic disease that confers high risk for coronary heart disease events, or which can be considered as an equivalent to already having a coronary heart disease or a risk of that? Clinical coronary heart disease, a patient having evidence of coronary artery disease on ECG, TMT, 2D echo, or troponins. Symptomatic carotid artery disease. Now, as we said, cardiovascular, carotid arteries also do get atherosclerotic plaques. So if a patient is symptomatic with carotid artery disease like recurrent TIAs, recurrent vertigos, central vertigos, and the Doppler study shows carotid atherosclerosis, then that is equivalent to a coronary heart disease risk. Peripheral arterial disease. Peripheral arterial disease due to smoking or due to diabetes, but a documented peripheral arterial Doppler showing arterial stenosis is again equivalent to coronary heart disease risk. Abdominal aortic aneurysm is also equivalent to a coronary heart disease risk. What are the major risk factors other than LDL that modify LDL goal? One, we know that LDL cholesterol level modify LDL goals. Other risk factors that affect the LDL goal of a particular patient. Cigarette smoking. Add to this even tobacco chewing. Hypertension. BP above 140/90 or any patient on antihypertensive medication. Low HDL cholesterol below 40 milligram per DL is also a risk factor. Family history of premature coronary heart disease event, an infarct or LVF in male first degree relative below 55 years, or a similar event in a female first degree relative 65 years, under 65 years. First degree is parent or sibling. Age, men above 45 years and women above 55 years. Those of you who are in practice for more than 30-40 years would accept that in older days, we never had a young heart disease patient. We only had above 50. Most of the coronary artery disease was degenerative. Now we have lifestyle ailment. HDL cholesterol above 60 counts as a negative risk factor. All of the above are positive risk factors. So if you have a person smoker and if you have a HDL of above 60, that HDL cancels out one positive risk factor. Its presence removes one risk factor from total count. In ATP3, that is the internationally accepted adult treatment protocol for treatment of dyslipidemia, third edition, diabetes is regarded as a coronary heart disease risk equivalent. So I have two patients. One has suffered a myocardial infarction, underwent primary PTCA stent implant, no diabetes, no hypertension. Other one is a diabetic, normal ECG, normal stress test. Both are at equal risk for the next coronary event. Now, to calculate the 10-year risk of future atherosclerotic cardiovascular disease. It's categorized into those at low risk, where the risk is below 5%. How do you calculate? Just go on internet and type in risk score for atherosclerotic coronary artery disease or cerebrovascular disease or coronary vascular disease or cardiac vascular disease, and you'll get a lot of calculators. The commonest and most widely used is Framingham. Let me write down here so that you can just a minute. Give me a minute. Framingham's calculator. So using this calculator, if the risk is below 5%, that will be low risk. Risk is moderate, 5 to 7.5%. Risk is high if it is 7.5 to 20%. It is very high if it is above 20%. And these risk scores or percentage or a risk of coronary event in the next 10 years will decide on the LDL goal for that particular patient. So what are the treatment goals? Now, whatever the lipid profile report may give, if a patient with low cardiovascular risk below 5%, the goal is to bring LDL below 116. This patient need not be taken below 100. Moderate risk, 5 to 7.5%, below 100. High risk, 7 to 20% risk, below 70. And very high, above 20%, below 55 milligram. This should be reduction from the base level of the patient. You cannot say, oh, but he's 259 now. That doesn't matter. If he falls in high category, you have to bring it down by 70%. That is the purpose of this discussion today. So evaluation of LDL goals have changed over decades and they have become more stringent. Initially, it used to be below 100 is optimal. You achieve below 100 and you have arrived. Then it became below 70. Then it became below 50 or 55. And future, because see, continuous research is going on, LDL below a certain level, does it still confer a risk? Do people still die? How many people die of LDL 50? No other risk factors, die of coronary infarct. Then future may bring it down to maybe below 39. We don't know. But we have to be prepared. And this is how the evolution of LDL cholesterol goals have occurred. This is not my study. This is from European Heart Journal 2020. Most of today's talk is from research studies. I have only taken efforts to create presentations, not copy-pasted the slides. Now, this slide is very important. Even I learned of it when I was preparing this talk. Please take a snapshot of this. Intensity of lipid lowering therapy or LLT. With each treatment, how much is LDL going to go down? Moderate intensity statin will reduce LDL by 30%. So if you are at 200, it will bring it to 140, not beyond. What are moderate intensity statins? Atorvastatin 10 to 20, rosuvastatin 5 to 10, simvastatin 20 to 40. Others we don't use. High intensity statin will bring it down to 50%. So if you are at 200, it will bring it down to 100. And what are high intensity statins? Atorvastatin 40 to 80, rosuvastatin 20 to 40. Then we have a very good reduction when you combine high intensity statin with ezetimibe, 65%. Then there are newer drugs, PCKK9 targeted siRNA therapy, inclisiran, injectable. PCKK9 inhibitor, alirocumab or evolocumab, again injectable, 50% and 60%. One of these combined with high intensity statin, 75%. And one of these combined with high intensity statin plus ezetimibe, 85%. So imagine a patient of LDL 290. And I want to bring him below 55. I need the last three. I agree that currently we are not using injectables for LDL lowering, but we are talking of future. In next 2 years, or maybe in a year, it will happen. And when a cardiologist prescribes that, your patient is going to come to you because they will be shocked that an injection every 14 days to reduce cholesterol, they'll come and ask you. And your knowledge that time is going to be very helpful. So these are pharmacological lipid lowering therapies. High intensity statins, 50% LDL reduction. Moderate 30%. Ezetimibe is selective cholesterol absorption inhibitor 20%. So you combine high intensity with ezetimibe, that comes to 70% or 65%. And there's a new drug, bempedoic acid, which we are still not using. The O here indicates that these are all oral therapies, and I indicate that these are injectable. This is again from Global Heart Journal 2022. Now, what is the goal of treatment and which patients fall into these categories? LDL goal below 116 in a low risk patient. The score should be below 1%. Moderate 100 milligram target, score 1 to 5. Who's this patient in moderate? Young patient, type 1 diabetes, age below 35. Type 2 diabetes, age below 50, without other risk factors. This also is from a proper study, CKD, chronic kidney disease, diabetes mellitus score, systemic coronary risk evaluation. Then we have a high risk, target below 70, score is 5 to 10, markedly elevated single risk factor. In particular, total cholesterol above 310, LDL above 190, BP above or equal to 160 by 100, family history without other risk factors, moderate chronic kidney disease, eGFR between 30 to 59, diabetes without target organ damage. What is the target organ damage? Diabetes alone does not kill anyone. Diabetes only kills if there is a target organ damage. Cerebrovascular disease, diabetic retinopathy, diabetic coronary artery disease, diabetic nephropathy, and peripheral arterial disease, diabetic foot. And diabetes is not partial. If a person has retinopathy, he is bound to have some evidence of coronary artery disease. If a person has a coronary artery disease, bound to have some amount of nephropathy. With diabetes of more than 10 years duration, any other risk factor like cholesterol. Then we come to high or very high, target is below 55. Which patients fall in this? Atherosclerotic coronary artery disease, either clinical or imaging, score about 20 or about 10 or about 20. Family history with atherosclerotic cardiovascular disease with another major risk factors like a diabetes, like a high hypertension, like smoker, severe CKD, eGFR below 30. Please keep in mind, most of the CKD patients will die of coronary events and not chronic kidney disease. Diabetes with target organ damage, 3 or more than 3 risk factors, or type 1 diabetes of long duration, more than 20 years. So this also I would request you to please take a picture. How do you decide on what treatment to give? Consider 4 aspects. What is the patient's burden? What is the risk of ASCVD? Patient needs, what is the patient's goal? Medicine efficacy and safety, how effective and how safe the medicine is. And patient preferences. Patient says, I don't want injectables. I can't afford injectables. So what are the choices of lipid lowering therapy? We're giving an example. Starting LDL 259. Add high intensity statin, rosuvastatin 20 milligram, brings to 50% reduction in LDL. Resulting LDL 129 milligram per DL, 50% reduction. It will not go below this if you continue only rosuvastatin or increase it to 40. Now we have to add ezetimibe 10 milligram once daily, additional 20% reduction in LDL, brings it to 103. Now we need more reduction. Consider adding injectable evolocumab 140 milligram subcutaneous every 14 days. Additional 50% reduction brings it down to 51, the target of the patient. This is how you have to go. Choices of lipid lowering therapy, 259 to 55, not possible with monotherapy. You have to consider dual or triple therapy. Then comparing hypertension and dyslipidemia. Hypertension and dyslipidemia both are found in patients with high atherosclerotic coronary vascular disease. Lifestyle intervention required in both. Commonly requires more than one agent for treatment. Commonly requires more than one agent for treatment, both of them. And in select cases, if the values are very high at baseline, you initiate combination therapy right in the beginning. And here also in LDL cholesterol, patients will benefit more with combination therapy upfront, especially those with very high ASCVD risk. Again, repeating cardiovascular risk assessment, very high CVD, start statin ezetimibe, reduction 50%, add PCSK9 targeted therapy or bempedoic acid. Extremely high, you start with 3 drugs, reduction 50%, and no further action needed. Some, age at which a coronary event is likely to occur. These vertical lines show 20, 30, and 40 years. A person who gets infarct around 20 years of age is the etiology is most likely severe hypercholesteremia from birth, most likely familial. People who will get around 30, moderate hypercholesteremia starting in teens, genetic and lifestyle, plus minus. And today, the lifestyle of kids. If you check their lipid at 12 and 15 years, I'm sure you'll be shocked. They'll be much more than parents. People who will get around 40, modest hypercholesteremia from adulthood, purely lifestyle, no familial, no genetics. The horizontal dotted line is the threshold of onset. And this is lifelong low LDL cholesterol. That lifelong low LDL cholesterol, also called hypolipidemia, is purely genetic. I have a patient whose LDL always was 45-50, whose triglyceride was 80, whose total cholesterol was 110. But he was a diabetic, he was obese, he was hypertensive. And from very early, at the age of 40, he was put on 5 milligram of rosuvastatin. And till today, just 3 months back, we did a study echo, which was bang normal. The cardiologist was surprised. So, lifelong low LDL cholesterol therapy at an early age, just see, he is not likely to get an infarct even at 70. So, it's not that if your LDL is low, you need not take statins. If you have other risk factor of atherosclerotic disease, if you calculate like this, then they will require a low dose, a moderate intensity, that is 5 milligram of rosuvastatin or 10 milligram of atorvastatin. A case we'll discuss: 58 male, type 2 diabetes mellitus, hypertension, dyslipidemia, peripheral arterial disease. So this patient has risk factors: age 1, diabetes 2, hypertension 3, dyslipidemia 4, peripheral arterial disease 5. CAD anterior STEMI with PCI and proximal LAD in 2022. So he's had a clinical event of coronary artery disease that becomes 6 risk factors. He's on metformin 850 TDS, enalapril 20, metoprolol 50, rosuvastatin 40, ticagrelor because he had undergone an angioplasty in 2022, the Brilinta, and aspirin. BMI 28, BP HR within normal limits, TC 198, LDL 90, HDL 39, another low risk factor, and TG 230. Macroalbumin within normal limit, kidney status normal. Now 3, 3, 6, and 2, 8. 8 risk factors in this patient who is feeling comfortable that is undergone 1 stent implant. His LDL is 90, his target is below 55. With goal below 55, ezetimibe 10 was added, will give 20% reduction. He's at 90, he'll come down to 45, 51. So this is, my dear friend, the thinking of LDL cholesterol. Type 2 diabetic mellitus is at a higher risk of ASCVD despite lipid-lowering therapy. Benefit of adding ezetimibe was enhanced in patients with type 2 diabetes mellitus. This is a study. And goal of LDL cholesterol is 55 milligram per DL. Change thinking. We always say patient has LDL of 150. I will give him 3 months to bring it down by lifestyle management. Don't do that. In those 3 months, he may be dead. Again, from European Heart Journal 2022. Maximize LLT from beginning. If you know the ASCVD risk, if your thinking changes, no, then you will start LLT very soon. Use combination LLT, consider percentage LLT reduction needed to reach the goal. Use initial combination therapy if larger LDL-C reduction is required. And high and very high ASCVD, dual or triple combination therapy generally required. ASCVD risk reduction in type 2 diabetes. Now here some anti-diabetics also help in LDL risk reduction. SGLT2 inhibitor, dapagliflozin and empagliflozin reduce the risk of ASCVD, and GLP-1 RAS, dulaglutide, semaglutide and liraglutide also reduce the LLD risk. So consider one of these two patients, one of these two group of drugs in patients with diabetes with high risk of ASCVD, and which specifically patient benefit from change in hyperglycemia treatment. These are evidence-based guidelines. Address modifiable risk factors, hypertension, hyperglycemia. Now see, if the patient has a risk of failure, LVF or heart failure, you give SGL2 inhibitor, dapagliflozin. Patient has an atherosclerosis risk, then you give GLP-1 RA. Dyslipidemia, including triglycerides, has to be treated separately. We are not touching it because this talk is purely on LDL, and also lifestyle is always very important for the drug to achieve that target. Proposed algorithm for evaluation of statin-related muscle symptom. Now, a lot of patients will come to you that after I start a statin, I started getting muscle pain. Is it true muscle pain, or is it hear and say, a lot of WhatsApp messages come up. So assess patient expectation, balance discussion of desired versus adverse effect before you start statin, and we both should be educated. Statin initiation per clinical guidelines, statin associated muscle symptoms, mild, moderate, continue if the patient tolerates, severe, discontinue statin. Now, if you're discontinuing statin, what are the causes? Rhabdomyolysis, kidney injury. So do a creatine kinase, total creatine kinase. It should be more than 10 times upper limit of normal. So if your upper limit of normal is 80, it should be above 800. If it is myositis, mild CK elevation, myopathy, you will be able to see objective weakness. Power would have reduced from 5 to 4 or 3. Or is it autoimmune myopathy? Myalgias, bilateral proximal muscle pains, CK creatine kinase is normal. Routine monitoring of creatine kinase in asymptomatic patient is not recommended. However, when patient becomes symptomatic, muscle pain and weakness, urgent creatine kinase measurement is recommended as per the 2016 ESC/EAS guideline for management of dyslipidemia. Then once you stop, or rather when the patient complains, address nocebo effect. What is nocebo effect? It is reverse of placebo effect. The nocebo effect is the opposite of placebo effect. It describes a situation where a negative outcome occurs due to a false belief or a preconceived notion. If it is nocebo, re-challenge statin or give non-statin therapy, purely lifestyle management. Alternative statin, if you're giving Rozu, give Atorva. If you're giving Atorva, then you give Rozu. Give a lower dose, decrease dosing frequency. If you're giving daily, try alternate day. Although not guideline based, but try that way. Ezetimibe, PCSK9 targeted therapy or bempedoic acid. Decide which one you want to give. Summary, the greater the risk, the greater the need for LDL reduction. Focus on absolute LDL reduction. Many laboratories give calculated value. Do not accept those reports. Calculate for every patient at increased risk. Identify the LDL cholesterol goal based on the risk. Calculate required LDL reduction needed to reach the goal based on the patient's baseline LDL, which is obtained after 12-hour fasting. Select lipid-lowering therapy based on required reduction in LDL to meet the goal. Consider early combination therapy. Do not hesitate. Assure patients that safe and effective LLT is available if they cooperate. They have to cooperate. That's all today for friends. Have a nice weekend and let's meet next week.